afternoon. I'm happy to be here for the third time and happy to show you the progress I made in the last 9 months. There is an ongoing debate whether metabolically healthy obesity truly exists. And whether this obesity without the traditional metabolic parameters, and these patients who are suffering from this, they have an elevated cardiovascular risk compared to their normal weight counterweights. So actually the unmet need here is for clinicians as well as for the patients to know and to have a very clear guidance whether these patients need extra care and maybe a new and proactive cardiovascular risk assessment, and of course to know how to treat these patients. So our meta-analysis of 13 trials have revealed that actually it is indeed that metabolically healthy obesity have almost 30% higher coronary artery calcification even when we have a very lenient definition of obesity and metabolic health. And if we have a more strict definition of obesity and metabolic health, then this risk is actually doubled. So it means that the definition, how we define metabolic health and obesity, indeed matters. So therefore we believe that those patients who are obese, regardless of metabolic dysfunction or metabolic abnormalities, will need to have a cardiovascular risk assessment to ensure a better cardiovascular outcome and to save maybe more lives. So my name is Judit Eleonóra Nagy. As you can see, my subject is obesitology and atherosclerosis. And though there are available, very effective weight loss products available already, and more is coming in the next couple of years, but I truly believe that in case of obesity, prevention is the key. So I have 3 ongoing projects. The first one is a meta-analysis investigating the lipid profile of obesity phenotypes in atherosclerotic prediction. The second one is very similar in structure. However, this time I will look into the inflammatory panel of the obesity phenotypes. And the third one is a registry project where I would like to examine the Eurostat data set on the health, not only the health burden, but more about the economic burden of obesity. So the first one, I think it's fair to say that obesity has become a global pandemic of unprecedented proportions with far-reaching consequences, not only for the individual patients, but also for the healthcare providers and for the economies worldwide as well. Atherosclerosis and obesity is very closely linked, as obesity being the major risk factor of the development and the progression of the atherosclerotic plaque, and leading up to the #1 killer of diseases worldwide. Obesity contributes to atherosclerosis through different pathways. The first one is a chronic low-grade inflammation. I will talk about a little bit later. And the second one is the metabolic dysfunction, including abnormal lipid profiles, hypertension, and endothelial dysfunction. Actually, obesity is a remarkably, or unfortunately, a very diverse disease by manifesting itself among individuals very differently. So what I really want to show here is that there is a very interesting phenotype. The phenotypes are those kind of manifestation among individuals, that how bodies are actually processing food, how they store fat, and how actually they react to different weight loss methods. And clinically, there is a very interesting phenotype. It's called the metabolically healthy obese phenotypes, because you as a clinician, you might come across with these patients, and they are, apart from being obese, they have no other medical issues. So the question is what to do with these patients. How long can you ignore their obesity? So we wanted to find something and to have an answer that is there a biomarker, and if so, is there a lipid, and which lipid biomarker that have the highest predictive value for atherosclerosis in the different obesity phenotypes. So I was using the PFO framework when the population is actually the metabolically healthy or unhealthy overweight and obese patients. The factor is the different lipid parameters, the total cholesterol, LDL cholesterol, triglycerides. And the outcome is the atherosclerosis measured by the coronary artery calcium score, which is a well-established and really good risk stratification tool for the subclinical atherosclerosis. So actually, we have done our research on 3 different domains, which yielded altogether almost 29,000 articles after the duplicate removal and the abstract and title selection. We ended up with 13 articles. So here is the progress of my first project. As you can see, I already have some figures and tables, and I'm happy to show you some of them. So the results question. The first one is that healthy and obese, is it a fact or fiction? The second one, that is metabolically healthy obesity is associated with elevated coronary artery calcium score compared to their metabolically healthy normal weight counterparts, or the metabolically healthy not obese counterparts, because it makes a difference. We can define obesity and metabolic health in a very lenient way when we say that metabolically health is the absence of any kind of metabolic abnormalities, and we also can define non-obesity as normal weight or normal weight plus overweight. And we can also have a very different definition and a more strict definition where we say that metabolic health is still allowed to have 1 or even 2 metabolic abnormalities. And the third question, that is there a predictor, either a metabolic or inflammatory predictor parameter to drive the significance? So here are the results, which was strikingly right after the data selection. So some of the trials defined non-obesity as normal weight, but some of them also added the overweight, which caused a huge confusion and a really heterogeneous results. Secondly, there are at least 50 metabolic health definitions. It's either the absence of any kind of metabolic abnormalities, some of them measuring the weight, measuring BMI, measuring waistline. So there is really very heterogeneous results. So here is one of my results. It actually the lenient definition, meaning is that we are very lenient how we define obesity and metabolic health. As you can see, metabolically healthy obese have almost 30% higher coronary artery calcium risk than their normal weight counterparts. If we have a more strict definition, this ratio is already doubled. So I'm happy to show you that this abstract is already accepted for the European Association of Diabetes Congress for this year. So we will have a 5 minutes oral presentation on these results. Of course, we have some limitations. These studies are cohorts and cross-sectional studies. There is a huge variability among the studies depending on race, depending on age, and so many other reasons. We already know that BMI is not the best KPI for distinguishing lean muscle, lean tissue, and fat. And also the coronary artery calcium is only one outcome of the subclinical atherosclerosis. We did try to have a broader, but then we ended up nearly 50,000 or even more articles, so we decided to be a bit more focused. So this is my second trial or second project. I will not go into that, but we will really interested to see the metabolic and also the inflammation panel. So we will see. We already have a lot of suspicion is that how we go, because the first project is ended up with high selective CRP results. Here are the preliminary research, and just a couple of words about my third project, which is a registry trial. Until this moment, we were talking about the health burden of obesity. In this one, I would like to look into the economic burden of obesity and to examine that how much time, how much days obese patients are missing out for work, and I would use the Eurostat data set to examine these. So here's the progress of this Eurostat data. And here you see the specific goals, how I'm going to finish all of these. And to finish this, I would like to quote Einstein: intellectual growth should commence at birth and cease only at death. Thank you.
Thank you. First of all, congratulations to the topic and for your presentation. Questions, please?
Yeah, thank you for your beautiful presentation. I would like to ask if you see any chance to change the definition of metabolic health?
To be very honest, the more I'm getting into this, the less confident I am that it will be ever a kind of finalized and kind of defined how we define metabolic health. So that caused the confusion early on in our meta-analysis. So hopefully, because as we already see that obesity is getting into the focus of healthcare. So hopefully metabolic health as a comorbidity will be just as important to define very clearly, just like hypertension cuts off.
Thank you.
Hi, congratulations on your presentation. As you said that BMI is tricky because it doesn't differentiate between muscle and fat. Are there any other indicators or scales or anything that can use to measure body fat? Maybe that scale that I can't remember right now that measures body fat, the in-body scale.
Mm-hmm. Yes.
Maybe but is that used in any of the studies?
Yes, there are, but the question is that how available for an everyday practice, because the BMI is very easy to calculate, just like the waistline, the waist circumflex. So I would say that for a time it will remain, but hopefully there will be some evolution on. There are many other scientific methods to show, to distinguish the lean tissue and fat. But as an everyday practice, I think we are not there yet. Even obesity is not diagnosed normally. I mean, I was trying to search in the Hungarian database for obesity, and because there is no treatment reimbursed, therefore doctors are usually not diagnosing it as a disease itself. So we go into these vicious circles with this.
Thank you.
Thank you for your presentation. My question is, do you see any difference between the lifestyle, as your personal opinion, or anything between the metabolically healthy and unhealthy obese people? Like, did they exercise more, for example?
I'm not a clinician, so I'm not coming a lot or in contact with those patients, but in the articles, definitely. So it seems that whoever is doing sport at least 3 times per week have much better metabolic status than those people who are not. And recently it was coming out an article on female patients who were normal weight but not doing sport at all, and there is another group, a control, who were obese, but they had doing sport very regularly 3 times per week. And the result was very surprising because the obese patients were much better off regarding cardiovascular risk. So indeed there must be some, and there are a lot of articles showing that.
Thank you.
or it's only sport, but lifestyle is definitely an effect.
Just very short question. Is fatty liver, which is a metabolic associated fatty liver, mentioned as a metabolic unhealthy condition in the literature?
Yes,
So
yes, there are.
Is it listed?
Yes, yes, it's getting into the picture. I think because of the obesity treatments, of more availability and more indication coming to treat these disease. I think it's more and more it's coming into the picture.
Thank you.